Okay, guys. Here we are getting ready to start Unit 8. We're actually starting it right now, our final unit. This is a short unit. There's only 2 lectures. This lecture that we're going to do today is on the urinary system. It's only, I think, 8 slides, so that should be a pretty quick, hopefully short video. And then our next lecture, final lecture, will be on the reproductive systems. Systems being 2, male and female. So without further ado, let's get into it. My screen, okay. So as far as the urinary system goes, there are 6 total organs: 2 kidneys, 2 ureters, a bladder, and a urethra. As far as that goes, pretty simple. We'll spend the majority, actually, of our time talking about the kidneys, which are the primary organs. They're the ones that produce the urine. They're the ones that filter and do the majority of the work. The rest of the structures are either just a couple tubes that carry the urine, or the bladder that holds the urine. Majority of our time today will be on the kidneys. I've listed here what the kidneys do. They maintain homeostasis by ridding the body of waste and recycling necessary elements. They're also involved with non-waste elimination recycling processes, which includes maintaining our blood volume. Think back to when we learned about the blood a few weeks ago. We learned that over half of our blood is water. So by controlling how much water we retain or how much we lose through our urine, we can determine how much blood we have. And that's what blood volume is. In doing so, that also helps regulate blood pressure, because more blood needs more pressure. That's not the only way that the kidneys help regulate blood pressure. They're also part of, of a pretty significant blood pressure regulating system called the renin-angiotensin-aldosterone mechanism. It's super complicated stuff that I won't get into in this class. Just know that's another way that the kidneys are very involved with blood pressure. Kidneys are also involved with maintaining normal blood composition, and by blood composition I mean what's in the blood. Same thing, kind of what I've been talking about, controlling how much water we lose, how much salt's peed out, so on and so on and so on. So that's how we maintain blood composition. Our kidneys help maintain normal body and blood pH. They do so by regulating the amount of hydrogen ions that we lose out in our urine. So very important. And then 2 very important chemicals that our kidneys produce, or secrete, whatever you want to say. Calcitriol, which is a hormone that helps with calcium homeostasis, and then erythropoietin, or EPO for short, which is a hormone that regulates the production of red blood cells. So super, super important. Okay, as I mentioned, the rest of the structures really just are conduits for the urine to be transported, or a sac, in the case of the bladder, to hold it. The ureters are the tubes that connect our kidneys to the bladder. There's 1 associated with each kidney, so there's 2 total. They carry the urine down into the bladder. The bladder is the sac that stores the urine and waste until it's convenient from being disposed. When it is convenient, we expel the urine into what's called the urethra, which is the tube that transports it outside of the body. Now, pictured here at the bottom is an illustration that shows the kidneys, the bladder, the ureters, the urethra, along with some other things. We've talked about the adrenal glands before. Those are endocrine functioning organs that sit on top of the kidneys. The term renal always refers to kidneys, which you see several times, like the renal veins, renal arteries, so on and so forth. And that's why the term suprarenal is also another way to describe the adrenal glands. Supra, remember, means superior. This happens to be a female, so that's why we can see uterus, some ovaries, oviducts, things that we'll talk about in the next lecture. One thing I want to kind of touch on real quick, we'll talk a lot more about in the next lecture, is, and later in this lecture, is the urethra is something that we'll see differences between men and women. It's much shorter in women than it is in men, and that's something we'll talk about And this will be one of the very few times this semester where we've kind of seen differences between a male body and a female body. Because, for the most part, other than size differentials, like men have bigger muscles, bigger bones, that kind of stuff. Men and women are pretty well built the same, with a few exceptions. And here we'll see some of those exceptions, more so in the next lecture. All right, let's talk more about the kidneys. There's a pair of them. They're reddish. They're kidney bean shaped, located just above our waist. Considered to be retroperitoneal. We talked about that term in our last lecture on the digestive system. They sit behind the peritoneum of our abdominal cavity. So they're pretty far back in there, covered with a nice shiny membrane. They lie to the right and left of the spinal column and are protected by the 11th and 12th ribs, our last two pair, and the thick back muscles more so posteriorly. Right kidney sits a little bit lower than the left kidney, and that's because we just learned this the other day. The liver occupies a very large space over there on the right side of the abdomen, and so you can see that if I scroll back to the previous page. Very, very subtle, but it is a bit lower than the left kidney. Typical kidney is going to have about 10 to 12 centimeters or 4 or 5 inches in length, be about 5 to 7 centimeters or 2 to 3 inches wide, and about 3 centimeters or an inch thick. So not too big, but fairly good sized. Weight about 4.5 to 5 ounces, and they're surrounded by 3 layers of tissue. The renal capsule, which is the deepest or innermost adipose capsule, which surrounds it, and then renal fascia, which is the superficial outside capsule or ischemic layer. Let's talk about the renal capsule, which you can see here in our picture at the bottom. These pictures are essentially the same thing. This is just a schematic of it. This is a real deal dissected picture of a kidney, so we can see and kind of compare and see the same things, which is pretty cool. Of those 3 things that I just listed off, the only one of those that we will see in the pictures at the bottom will be the renal capsule. This is the inner fibrous membrane made up of dense irregular connective tissue. So very, very strong, a lot of collagen fibers running in all sorts of different directions. And it's continuous with the outer coat of our ureters, functioning as a barrier against trauma and helping maintain the shape of the kidneys. Surrounding it, not visible in these 2 pictures, is the adipose capsule. The term adipose is a fancy word for fat. So this is the middle layer of fatty tissue that surrounds the renal capsule, protects kidneys from trauma, holds them in place within the abdominal cavity. So there's a nice cushion. The renal fascia is the superficial thin layer of dense irregular connective tissue, helps anchor our kidneys and the adrenal glands to surrounding structures in the abdominal wall. Deep to the renal capsule is where you'll find what we call the renal parenchyma. This is glandular tissue that helps form the urine and is divided into 2 zones: the renal cortex and then the renal medulla. And cortex here is shown in this kind of light tan portion of our picture. The darker brownish colored region would be the renal medulla. Those are the 2 primary parts of the renal parenchyma where the urine is formed. Cortex is on the outside. We know that. We've talked about the word cortex. We've talked about the term medulla since the very first lecture of the semester. Now, what's neat about, kind of unique, I should say, about the cortex here, if I zoom in a little bit, notice that this kind of tan shaded stuff projects more to the inner parts of the kidneys. Okay? These are called renal, renal columns. You can see one's labeled right there. So they are just projections of the renal cortex that push into the middle of our kidneys. And they separate the renal medulla into these kind of triangular shaped regions, each of which is called a renal pyramid, which we see one is labeled right here. So that's what I'll just read off here. So renal cortex on the outside is the extensions called renal columns, project toward the center, divide the inner renal medulla into about 6 to 10 renal pyramids. Down here at the bottom, we see this line surrounding one of those renal pyramids, the cortex on the outside, and then a half of a renal column. That creates what's called a renal lobe. Okay. So renal lobe consists of renal pyramid, it's overlying area of renal cortex, and one half of each adjacent renal column. Okay, if I zoom in at this picture up here at the top, we see this yellow kind of squiggly line, and it's labeled as a nephron. And you wouldn't be able to see this, and if I zoom over here to this picture, we don't see the nephrons, even though we can see parts of the renal pyramid, renal cortex, and that's because these are microscopic. And so we'd have to look at them under a microscope, very, very small. And there's not just one per kidney. In fact, there's about 1 million of them per kidney. But the importance of these is that they are the filtering structures that are found within both the renal cortex and the renal medulla. And they are what form our urine. And the urine then is formed. Eventually, that drains down into what's called a collecting duct, which then drains into a papillary duct, and then so on and so on and so on. Okay, so each urine formed by nephrons flows in a specific pattern from the renal pyramids. Each renal pyramid is joined to a cup called a minor calyx, and that's what this structure is here. There's another one here. There's another one here, and they receive the urine from a papillary duct. Notice we've got a nice arrow flow chart here. So papillary ducts drain the urine into a minor calyx. Then those minor calyces is plural, merge together to form what's called a major calyx. And you can see the same thing over here. Minor calyx, here's another, and coming together. Here's the major. The majors eventually merge together to form what's called a renal pelvis. The renal pelvis is just the beginning of the tube known as the ureter that drains the urine down to our bladder. And that renal pelvis and the ureter emerge from the indented portion of our kidneys, what we call the renal hilum. And we've seen the term hilum, several times here the last few weeks. Talked about it, like in our lungs has a hilum. That's the indented portion of our lungs. This is the indented portion. It's on the concave side of the kidneys. Also the point where renal arteries come in, renal vein leaves. There's also lymphatic vessels. There's nerves, so on and so on. And our hilum expands into a cavity within our kidney called a renal sinus, which is shown right here. And just this kind of just general area. Okay, so touched on pretty much everything in this picture. We're going to talk about arteries and veins here on this slide. Okay. Something that, if you think back to our lecture on blood vessels, one of the pictures that we colored was the major parts of the aorta. Okay, major parts of the aorta. Remember, the aorta is the blood vessel that receives blood from our left ventricle, and that's the first blood vessel for structures that receive blood from the systemic circulation. One of the only blood vessels that I colored coming off of the abdominal aorta were the pair of renal arteries. And that's because our kidneys, sitting around at rest, like most likely probably are right now, and I am, we get about a fifth of our blood, almost a quarter of our blood goes to our kidneys each minute, even though our kidneys only account for 0.4% of our overall body weight. So a lot of blood goes to our kidneys when we're hanging out. Now that number will go down as we perform exercises and that kind of stuff because our muscles need it more. But just shows the importance of circulating blood to our kidneys, which begins with the abdominal aorta and the two branches we call the renal arteries. We showed those on the previous page. We can show them here in our picture at the bottom of this page as well. Okay. Just before, after entering the hilum, each renal artery divides into a few what we call segmental arteries. So here's the renal artery just before it enters the indented portion. You can see, in this case, a couple segmental arteries branching. And then from there, we're going to have a lot of branching going on. The segmental arteries branch, okay, and those form Number 3, what we call interlobar arteries. These travel between each renal pyramid. Remember, inter means between, and then interlobar, now we know why we call it that, because it travels between the lobes, which we just learned. A lobe is one of these regions. So an interlobar is going to travel out through that specific region between the pyramids. Then they branch into arcuate, or arcuate, I can't ever pronounce that correctly, and then interlobular, or cortical radiate arteries. And those pass upward into the cortex. Now we're getting really, really small. So if I come back and zoom in, so here's our interlobar traveling out towards the very outside of our kidney. Here's the arcuate and the cortical radiate artery, or these are also known as interlobular. And they used to be called interlobular. This most recent version of the textbook has kind of changed that to call them cortical radiate. I always tell students to make sure you know them both ways. And so over here, next to cortical radiate arteries, it's got a nice little flow chart to kind of help break you down. Maybe be a good idea to write interlobular arteries. Okay. Probably change it because interlobar and interlobular can be confusing. But make sure you know them both ways, because you will see it that way from time to time. Okay, branches of arcuate arteries, interlobular or cortical radiate arteries that pass upward in the cortex. As the interlobular artery ascends to the cortex, it branches into a series of what we call afferent arterioles. It says, as previously discussed, I've kind of switched around the order of this lecture. We haven't talked about those yet, but we will when we talk about nephrons. And here's a zoom in of this little segment of our picture to show an afferent arteriole, which is the blood vessel that feeds this yellow squiggly line. That's our nephron that I was talking about on the previous page. This is where we're going to first bring blood in and filter it. And afferent arteriole will then come into our nephron and then turn into a capillary network called the glomerulus, or aglomerulus, which is where filtering takes place. We pull out a lot of stuff from the blood, not everything. We're going to leave like the blood cells and the proteins, the big stuff, and we're going to pull out the water and the small stuff. Okay. What doesn't leave the blood will then leave the glomerulus and form what's called an efferent arteriole. And efferent arteriole still hangs out and surrounds the rest of the nephron as what we call peritubular capillaries. And so I'm reading number 6 here. Efferent arteriole leads to a plexus of peritubular capillaries, which pick up the water in solutes reabsorbed by the renal tubules. This will make more sense when we talk about a nephron in the next couple of slides. And these capillaries drain into interlobular veins. So then after we zigzag around with that zigzagging yellow tube, we're now ready to take that blood away from the kidneys, which means we start it all over again. And from the peritubular capillaries, blood flows into the cortical radiate veins, which you could also, might be a good idea, write out somewhere next to them, interlobular veins, then into the arcuate, and into lobar, then into the renal vein, and then that's going to take it back to that inferior vena cava. Okay. So it's all just the same way, just in reverse as the arteries. Okay. One thing I didn't point out was what's called the vasa recta. Vasa recta, we'll talk about more on the next page. This encircles what we call the loop of Henle, which is this little segment of our nephron. Like I said, it'll make more sense, but I wanted to give you kind of an idea of the flow of blood before I talked about nephrons on the next couple slides. Okay. Over here on the right side of the page, pretty cool picture. This is what's been done basically is a kidney's been injected, not the kidney itself, but the blood that supplies the kidney with a certain type of chemical that will run through the blood and distribute out to all the blood vessels, both arteries there you can see in red and the veins there in blue. And then that chemical hardens up. What they did after that point was essentially just removed through a series of processes the glandular kidney material, and so what's left over is just hardened blood vessels essentially. So you can see, and I'd just like to point this out because it's really cool, just how much blood it goes throughout. It's just about any and every single spot within a kidney is littered with blood vessels, even though many of them are small. It's pretty cool to see. All right, let's talk about those kidneys now. This will help make sense of some of that stuff there on that previous page. As we mentioned, each kidney has about 1 million of them. 1.2 is, kind of the official average there, I guess. Each of our nephrons consists of 2 principal parts, the renal corpuscle and the renal tubule. Corpuscle is where we first filter blood. It's comprised of things that we just talked about: afferent arterial, glomerulus, and an efferent arterial. That's what we'll talk more about here at the bottom of this page. And then on the next page, we'll talk about the remainder of the nephron. So looking at these 2 pictures, these are essentially showing you what a nephron looks like. This kind of circled area right in here is the renal corpuscle. We'll talk about, go back to that page and talk about it. This is where we first filter the blood, forming urine. I shouldn't even call it urine at this point because it's not. It's called filtrate. Filtrate is a precursor to urine, but it's not quite urine yet. And that filtrate then funnels out through this long winding, what we call renal tubule. It dips down from the cortex into the medulla. We do a lot of passing stuff back and forth, and meaning some of the stuff that's in the renal tubule as filtrate will leave and go back into the blood. We basically just give it back to the blood. A lot of the stuff that's in the blood actually can then go back into the tubule. So it's a back and forth movement. Eventually, we come back out into the cortex and we zigzag some more. And eventually, about this point, it is finalized as far as forming urine. And then that urine is going to drain down into the collecting duct and then eventually out of the kidney, as we talked about a couple slides ago. And let's talk about the corpuscle some more. And once again, what we're going to be seeing here, this picture is just a zoom in at this segment of our nephron. This is kind of a simplistic version of that picture that was on that previous page, or that next page, I guess, that I was just showing you. Okay, so we're going to zoom in right here, okay, showing you the internal view of a renal corpuscle. Here's the afferent arterial, which is the blood vessel, like I said, that brings blood into the nephron in the very beginning. That blood vessel comes in. It's a distant branch of our renal arteries, okay? And then we can see what happens is that singular afferent arterial becomes a mass of capillaries. We call that a glomerulus. Okay? Now, this glomerulus is what's in red, but we don't really see it too well because it's surrounded by cells, look like little bugs to me. Each of those cells is called a podocyte, okay? And they create what's called the visceral layer of the glomerular or Bowman's capsule. What they have are these little leg-like or finger-like extensions called pedicels, okay? And they wrap around the blood vessels being the glomerulus, okay? And they create a barrier to prevent big stuff from leaving the blood, okay? If I zoom here at the bottom, what we're doing is looking at a section of that, okay? In yellow here, the innermost layer is just the glomerulus itself, and the glomerular wall made up of endothelial cells. Notice what we see though, a lot of little holes. Okay, these are pores or fenestrations, making this capillary very leaky. Okay, think of it like a dish strainer. And when you, or not a dish strainer, but a colander or strainer that you use to dump, macaroni noodles in water or spaghetti noodles in water in when you've, boiled them to where they're soft. So I like to use that analogy. Think of your noodles like blood cells, bigger than the holes, so they can't travel through the holes. But the water and the small stuff can definitely travel through those holes rather easily. And directly surrounding that inner layer is shown in blue here. It's basal lamina. And think of that like if you were to take your colander, put it in your sink, but first wrap the outside of it with like a coffee filter. And so put coffee filters all around it to the point where you've got another barrier to prevent stuff from going through. Okay. That coffee filter is going to still allow water, but it's not going to allow, you know, the bigger stuff to travel through. Okay. And surrounding that, shown in red here, is another membrane. It's like another layer of coffee filter. So it's like putting 2 layers of coffee filters on the outside of your colander. Okay. It's going to allow the water through, the very small stuff, and I'm talking very, very small stuff. I won't even give you numbers on it, but I'm talking super, super small. Things like ions and maybe a little bit of glucose and stuff like that. But you're not going to see blood cells. You're not going to see proteins, at least in a normal, hopefully anyway, situation. Okay. Now, surrounding the slit membrane are those podocytes, okay, with their finger-like extensions called pedicels. Okay. What those podocytes are going to do is they're going to create another barrier. Okay. They're going to wrap around. Okay. If I kind of show you my fingers a little bit better here. Notice I've put my fingers together. I've kind of locked them in. Okay. But you can still see through my fingers because there's little gaps. Okay. It's another barrier for big things. Okay. And those gaps are where you're going to find the slit membrane, okay, or the filtration slit as it's labeled here. And so it's just kind of help holding all those stuff together, all that stuff together, and just creates another barrier to prevent the big stuff from leaving the blood. Okay. So what ends up happening is the water, the ions, the small stuff, it's going to filter out of our blood and into this space surrounding it called the capsular space, okay, and forming the outside of the entire structure is what we call the parietal layer of the glomerular or Bowman's capsule. And that's just what surrounds the entire structure, which creates or prevents the filtrate from just going right back out and into the rest of the kidney. So there's only one place for that filtrate to go, and that's into what's called the proximal convoluted tubule, which is the very beginning of our renal tubule that we'll see on the next page. Now, what doesn't leave the blood, like I said, the blood cells, the proteins, some of the water, it's going to just end up going right out of the corpuscle via what we call an efferent arteriole. Okay. Now, this structure here, we'll talk about on the next page, and the cells called macula densa cells here, we'll talk about on the next page. But they're going to play an important role in regulating the formation of that filtrate and ultimately the formation of that urine. Okay, so let's move on to the renal tubule. This is a long winding hollow tube, extends from the corpuscle to the nephron, where it joins a collecting duct, which is shared in common with other nearby nephrons. We can call a renal tubule the urine collecting and concentrating tube. So this is where we finalize the formation of urine. There's 3 parts that make it up. What's called the proximal convoluted tubule, or PCT for short, loop of Henle or nephron loop, you'll also see it, and then the distal convoluted tubule. Okay, so zooming in, here's our blood coming into the first part of the nephron, the corpuscle, by way of an afferent arteriole, which then branches a whole bunch, forming a mass of capillaries called the glomerulus. We filter stuff out of the blood, forming a lot of water and small stuff called filtrate, which then drains out of the nephron, or excuse me, out of the corpuscle and into our proximal convoluted tubule. Okay. You ever heard the word convoluted? It means like a jumbled up mess. You can kind of see why we call it a proximal convoluted tubule. Okay. There's also a distal convoluted tubule, another kind of jumbled up region. Okay. As that filtrate flows out of our corpuscle, it zigzags, and this is all out in the cortex in the proximal convoluted tubule. They just have it labeled here as proximal tubule, but it's, you know, proximal convoluted tubule. Notice what's surrounding the yellow tubule. Okay, lots and lots of blood vessels, which are called peritubular capillaries. Okay? Those are the routes for stuff that was removed from the blood to get right back in. Okay? What we do in our kidneys every day is pull out, I'm talking like, it's like 45 gallons of filtrate a day. That's off the top of my head guess. I believe that's the number though. That's a lot. You think about like a gallon of milk. Okay, we don't pee 45 gallons of pee a day. If you do, you're full of it. Okay, not possible. So that means that filtrate, most of it has to get put back into the blood. And a lot of that getting put back into the blood, what we call reabsorption, takes place just in this very first segment of the renal tubule. And those blood vessels called peritubular capillaries just soak that water and other stuff right back up. And to do so, the proximal convoluted tubule has simple cuboidal epithelium with numerous mitochondria, but more importantly, it has a brush border. A lot of microvilli. Remember, those are the little finger-like extensions that face the lumen. In fact, if we go back to this page, we can see those microvilli. Okay? Lots and lots of these little finger-like extensions, creating lots and lots of avenues for that water to go back into the cells and then out into the interstitial space and then be picked up by the blood. Okay? So that allows for a great deal of reabsorption, which is where that stuff returns to the blood. We also do some secretion here, which means that the stuff that's in the blood that we didn't pull out already, will be pulled into the tubule. And, as I mentioned, the location of the proximal convoluted tubule is strictly out in the renal cortex. Okay. From the proximal convoluted tubule, okay, the filtrate's going to then flow downwards via what we call loop of Henle or nephron loop, which dips down into the renal medulla. So the inner portion of our kidneys. Okay, it does so by way of a descending limb, which goes down, and then we have a 180-degree turn, and we go back up out into the cortex via an ascending limb. Okay. So let's read through. This is a long U-shaped structure. Cells of loop of Henle vary from simple squamous epithelium to simple cuboidal and to simple columnar. Cells in the loop almost entirely lack microvilli, so there aren't those finger-like extensions that we just talked about, we saw in the PCT. There are kind of two, besides having ascending, descending parts, segments to a loop of Henle. And I can kind of show them better off here in the picture of the nephron on the right side of the page. And we'll look right here. Notice this, the width of the nephron loop right in here is very thin, okay, compared to right across in the ascending limb, it's very thick. Okay. The cells that form the loop of Henle on this side are very thin, and thus the limb here is very, very thin. That makes them very permeable to water. It means water can easily pass out of the loop and into the vasa recta, this network of blood vessels that surrounds the loop of Henle. Okay. Over here on the right side, the thick segment is thicker because the cells are thicker and they contain lots and lots of mitochondria. And this gives them energy so that they can actually pump out, which requires ATP. They pump out salt, okay, which is very, very prominent in the middle part of a kidney. They say if you were to lick or taste the middle part of a kidney, which I've never done, but people do eat kidneys, tastes very, very salty. Okay? And that's because of the thick segments that have the capacity to actively transport salts because of the ATP that they can produce. Okay? As I mentioned, the thin segments have simple squamous epithelium, so they're very thin, very permeable to water. Okay? There are two limbs to each loop. The ascending limb passes from the cortex to the medulla. There's a thin segment suddenly narrows as it descends. Ascending limb is a portion of the loop that turns 180 degrees, returns to the cortex. It contains a thick segment that widens the tube as it passes upward. Okay, the distal convoluted tubules, the final part of the renal tubule. It's distal to the loop of Henle and functions to conduct filtrate out of the nephron and into a collecting duct. And it's strictly found out in the renal cortex. If I zoom in at this picture, we can see the zigzagging, convoluted nature of it. Okay, so right here, I want to point out what happens. Okay, the distal convoluted tubule happens to pass right by that afferent arteriole that we talked about on the previous page. Okay. This creates, and I always tell students to circle this portion of the picture and label that as what we call a juxtaglomerular apparatus. If you know what the term juxtaposed, this will give you a heads up. If you don't, I'll tell you what it means. Juxtaposed is a term that's used in like photography. It means like next to. So the juxtaglomerular apparatus is a structure, it's a portion of the distal convoluted tubule that brushes past and is right next to, therefore, an afferent arteriole. And this is the next to the glomerulus. Okay. This interaction helps maintain homeostasis of blood flow. And if I go back to this picture, I told you I would talk about this structure here, these cells, and these cells. Okay. This is the distal convoluted tubule, even though it says ascending limb, it's really more so the distal convoluted tubule. And it has cells called macula densa cells that can communicate with these cells, the juxtaglomerular cells. Okay. These cells communicate with one another, and it enables, sorry, go upstairs, okay? Sorry, guys. What it allows for, and I always use it kind of a Barbie doll analogy, the slowing of things down if we're going too fast. So here's my Barbie doll analogy. I made this up a few years ago. It seems to work. Let's pretend that we're making Barbie dolls. We're all part of a team that's working on an assembly line. So assembly line, there's a conveyor belt. The Barbie dolls are moving down the line. Each person has a specific role in that assembly line. You know, somebody puts the legs on, somebody puts the head on, somebody puts the arms on, gets them dressed, whatever. And let's say that the conveyor belt starts right here at the beginning with the afferent arteriole, which is exactly what's happening. Blood coming in, and we're going to first form filtrate, then we're going to move on down the line. Stuff's going to be happening. Okay. If our conveyor belt's moving super, super fast and everything's going way too fast, you know, just like if we're putting Barbie dolls together, stuff's not going to get done correctly. And so what can happen is if we're moving too fast, communication can occur between the distal convoluted tubule cells, those macula densa cells, and the cells right here. Okay? And basically what they can do is they can hit a switch that slows the flow of blood in, which slows everything down. And thus it prevents us from losing too much water, too much salt and stuff in our urine. And so let me read through. So this interaction helps maintain homeostasis of blood flow. Granular juxtaglomerular cells are specialized smooth muscle cells, the afferent arteriole, contain mechanoreceptors, which are receptors monitoring blood pressure in the afferent arteriole. Macula densa are specialized cells in adjacent to the adjacent distal convoluted tubule. They contain chemoreceptors, so they monitor chemicals, things like sodium and chloride ions that are lost in your urine inside the tubule. So basically, it just helps fine-tune the making of that urine. Okay. Now, after the tubule, or excuse me, after the filtrate flows through the distal convoluted tubule, from there, we're almost done with the formation of urine, and that filtrate flows into what's called a collecting duct. Okay. Now, a collecting duct is shown right here. Notice right here, we show a branch that's going nowhere. It's not really what's actually happening. This has just been cut off, but connected to this would be all of this. And in other words, a collecting duct collects, we could almost call it urine at this point, but we'll still call it filtrate from multiple nephrons. Okay. So collecting duct formed by the joining of distal convoluted tubules of several nephrons. Collecting duct cells are cuboidal with a few microvilli. Collecting ducts within the medullary pyramids merge to form papillary ducts, which drain into the minor calyces of renal pelvis through the medullary papillae. So eventually, collecting duct, we can see several nephrons will be collecting that urine from it. Eventually, and this picture shows it better, collecting duct forms into a papillary duct, which then drains out into a minor calyx, so on and so on and so on, eventually into our ureters. Okay. Now, there are two types of cells that are present in the collecting duct in the very last segments of the distal convoluted tubule. Principal cells that respond to the hormones aldosterone, which is nicknamed the salt retaining hormone, so it would help if we have this hormone being released, pull any salt back into the body, and antidiuretic hormone, which makes us pee out less water. And so those cells help us either to lose more or less water and salt. There's also intercalated cells, secrete hydrogen ions into our urine, so it makes our urine a little bit acidic, but that helps in the long run to help control our pH. There's two pictures here at the bottom of the page to show the two types of nephrons. Over here on the left side, the majority of our nephrons are this type, what we call cortical nephrons, about 85%. We call them cortical because the majority of the nephron is out here in the cortex. Juxtamedullary, they dip down, and it's all because of the loop of Henle, much deeper into the middle portion of our kidney, into the renal medulla, and they create a more concentrated urine because they pull more water out in this area than our cortical nephrons, but not something specifically I tell you or ask you to know. Over here on the next page, I just included a full-size picture of a cortical nephron, so you can identify all those parts. I pointed most of them out. Afferent arteriole, where everything begins, glomerulus, surrounding the entire structures, the capsule, efferent arteriole. Then you get the proximal convoluted tubule, the loop of Henle, descending and ascending limbs, distal convoluted tubule. Go ahead and circle and draw in the juxtaglomerular apparatus. Probably a good idea to know the peritubular capillary surrounding all of this stuff. Then you go down into the collecting duct, papillary duct, renal papilla, minor calyx. What's nice, I like this little box here. It kind of gives you a nice flow chart for how that fluid is flowing, that what we call filtrate, eventually draining into a collecting duct. And at that point, it's essentially urine, which is then going to make its way to our ureters. Finally, get to talk about some different organs here. Last couple slides. Talk about ureters first. Ureters are muscular tubes passing in posterior to the bladder, actually filling it up from the bottom because they enter from the bottom side. They exit each kidney at the renal hilum, course downward in the retroperitoneum. And each ureter is going to consist of 3 tissue layers. Innermost is the mucosal layer, secretes mucus to help protect the ureter tissue from urine, composed of a mucous membrane with transitional epithelium. You remember back at the beginning of the semester, we learned that transitional epithelium was epithelium that had cells that could change their shape. So they can be like nice and boxy, cuboidal, and then they could squeeze down and become more squamous. But basically just enables the lumen of the ureter to get bigger as that urine passes through. Also making up the mucosa is an underlying layer of lamina propria made up of areolar connective tissue. Middle layer of the ureter is a muscularis layer. Contains longitudinal and circular layers from the muscle, helps form the urine for by peristalsis. That's the squeezing of the toothpaste tube, always pushing it forward. And then the outer layer is adventitia, made up of areolar connective tissue, where you find nerves, blood vessels, and lymphatic vessels. Ureters are quite a bit like your esophagus in that they're going to just push that urine downward, just like our esophagus pushed that food downward. It's not like flipping a coin down a well where all gravity is responsible for it. Gravity, I'm sure, does absolutely help with the movement of the urine, in this case downward, but peristalsis is the major means in which that urine gets where it needs to go. From ureters, the urine is going to fill up our bladder, muscular sac on the floor of our pelvic cavity. It's inferior to the peritoneum and posterior to pubic symphysis. Remember, pubic symphysis, that little piece of cartilage between your two hip bones. Here's a difference in males. It's located in front of the rectum. Females, it's in front of the uterus. Down here at the bottom, we're really mainly showing off here the bladder and then the urethra, which we'll talk a little bit more about on the last page. Two openings that fill the bladder up with the urine are called urethral openings. Those are the openings from the ureters, hence the name urethral. Don't get those confused with urethral openings, orifices, I guess. So the urethral openings, the two openings of the uterus. The internal urethral orifice is the opening that leads to the urethra, not to be confused with the external urethral orifice, which is associated with the urethra. This is essentially where the urine comes out of the body altogether. Okay. Together, the internal urethral orifice and the two urethral openings create a triangular shaped region within a bladder called the trijone, which happens to be a very common site of bladder infections. So trijone, smooth surfaced triangular area on the bladder floor formed by the urethral openings in the internal urethral orifice. 3 layers of tissue form the bladder, just like we saw in the ureters. Inner mucosal layers, mucous membrane, very similar to that of the ureters, except we have what's called rugae on the inside of our bladder. Rugae is here just like it's in our stomach, which was another kind of sac-like structure. Those are accordion-like folds that allow for expansion. In this case, not food, but urine to expand and fill up our bladder. The muscular layer of the bladder is the thickest. It's actually a special named muscle called the detrusor muscle. There's 3 layers of smooth muscle that form an inner longitudinal, middle circular, and outer longitudinal. And around the opening to the urethra, the circular fibers form what's called an internal urethral sphincter. And notice in parentheses it says involuntary. We'll talk about that on the next page. Inferior to it is the external urethral sphincter, which is a modification of the deep muscle of the perineum, shown right there. Notice in parentheses it says voluntary. Yes, it's very similar to what we learned in our last lecture when we talked about the anal sphincters. On the very outside, the most superficial coat on the posterior and inferior surfaces is called adventitia, layer of areolar connective tissue, continuous with the ureters. On the superior surface of our bladders, though, it is serosa, which is a visceral layer, or is a layer of visceral peritoneum. All right, let's talk about our last structure, the urethra. Okay, this is where we'll see some big differences in men and women. Regardless, though, if we're talking men or women, this is the tube that transfers urine out of the body, a process we mostly call peeing, but fancily is known as micturition. The urethra as a tube exits from the bladder and drains urine to the external urethral orifice, which is the exterior opening to the body or of the body that I pointed out on the previous page. Both men and women, or males and females, the urethra is the terminal portion of the urinary system, passageway for discharge of urine from the body. It's different in men in many ways, one of which is that it also discharges semen. So it's a shared tube. We'll talk more about it in the next lecture as well, because it's part of the reproductive system. And women has nothing to do with reproduction whatsoever. Let's talk about the male urethra first. It extends from the internal urethral orifice to the exterior while passing through the through the prostate. For that reason, that portion of the urethra is called the prostatic urethra. Then it passes through the deep muscles of the perineum, which is the floor of our pelvic cavity. We call that segment the intermediate or membranous urethra. And then finally, it passes through the spongy tissue of the penis, which is why we call that the spongy urethra. So here in our sagittal section, we see the 3 parts. Here's the prostate gland. This tube right here passing through it is the prostatic urethra. Then right here, there's the muscles of the perineum. This means that this is the intermediate, or as you might write, membranous urethra. And then the longest section of it is the spongy urethra as it passes through the penis. Okay. Total distance about 20 centimeters or 8 inches. Male urethra consists of deep mucosa and a superficial muscularis. Muscularis of the prostatic urethra is composed mostly of circular smooth muscle fibers, superficial to lamina propria, and these help to form the internal urethral sphincter that I showed you on the previous page. Muscularis of the intermediate urethra consists of circularly arranged skeletal muscle fibers of the deep perineal muscles that help form the external urethral sphincter. Several glands and other structures deliver their contents in the male urethra, which we'll discuss in our next lecture. Okay. So the total male urethra is about 8 inches. Female urethra is only about 1.5 inches. So quite a bit difference, about 5 times longer in women than men than it is women. External urethral orifice is located between the clitoris and the vaginal opening, structure that we'll talk about in the next lecture. And the wall of the female urethra consists of a deep mucosa and superficial muscularis. Mucosa is a mucous membrane composed of epithelium and lamina propria. Muscularis consists of circularly arranged smooth muscle fibers and is continuous with that of the urinary bladder. In both men and women, there's 2 urethral sphincters, just like there were 2 anal sphincters, an internal and an external. Remember, same thing, internal IN and involuntary go together. This is made up of circular smooth muscle. We know smooth muscle is controlled involuntarily, whereas the external is made up of skeletal muscle fibers, and thus is voluntary. Okay. Down here at the bottom of the page, I talked about these things in picture for the man. Over here on the right, we show the bladder and the urethra for women, along with things like the uterus, the vagina. These 2 pictures are going to show up in our next lecture, and they're going to have a lot more things labeled because we're going to be identifying things like the testes and spermatocord and vas deferens and so on and so on and so on. So kind of just wait, and you can highlight them now. We'll start identifying, but in the next lecture, we'll really start adding to it. So we have to do it again. So one thing I do want you to make sure you know, this box down here talks about the differences between men and women. Talked about the 5 times difference in men than it is in women. 3 parts that make up the male urethra, only 1 part in female. It's just a simple urethra. And then how it's a common duct for men for reproductive and urinary purposes. It's only urinary in females. So, okay, I will stop here.